Hello, everybody, and good evening, and thank you for your patience as we worked out a couple of quick little technical challenges. But welcome to Boulder Community Health's Community Health Needs Assessment Town Hall. My name is Grant Besser, and I have the privilege of serving each day as the president of the Boulder Community Health Foundation, as well as vice president of public affairs. Thanks for coming out. It's the eve of fall and probably the perfect illustration of that as we have a nice kind of cool rainy evening outside. So hopefully you're enjoying an evening at home, and I really appreciate your taking the time to join us and learn more about our work at BCH. Tonight, we're joined by a broad group of stakeholders from across our community, from city and county agencies to nonprofit partners, to the community that we serve each day, our patients, and of course, many members of the BCH community as well. Before we dive in, we're going to do some quick introductions around the horn. So I will turn it over to Dr. Robert Vissers.
Hello, I'm Rob Vissers, and I'm the CEO and president of Boulder Community Health. And again, welcome and thank you for joining us this evening.
And Sarah.
My name is Sarah Wise, and I am a director of nursing for behavioral health services. Glad to be here.
And Dr. Kaiden.
Hey, Ben Kaiden, I'm the chief medical officer at Boulder Community Health, and welcome.
And on drums, we've got Larry Novissimo.
Thank you, Grant. Thank you, everybody. This is Larry Novissimo. I have the pleasure of serving as the vice president of ambulatory operations here at Boulder Community Health.
Excellent. All right, Sam, next slide, please. And one more slide, please. Excellent, thank you. Like all Colorado health systems, BCH uses a systematic process called the Community Health Needs Assessment, which helps us to identify and analyze our local health needs and services. Tonight, you're going to have the opportunity to hear about our progress with the plan that we put into effect for 2020. That was a 2020 through 2022 plan that's addressing the health inequities and improving the health of community members, as well as what we're doing on the care coordination of those enrolled in Health First Colorado, which is Colorado's Medicaid program. At the end of this evening, we're going to be soliciting feedback that will inform the development of our strategies for our new plan that is currently in development that will cover the period of 2023 through 2025. Next slide, please. So the way this works with the Community Health Needs Assessment is every 3 years, we identify kind of what our most pressing needs are. We do that through a number of individual interviews as well as focus groups. This year alone, we met with 38 various community organizations in the discussion thus far. And tonight, that now covers our community, our patients, those that we serve each day to hear from you. We solicit community feedback, which then leads to us revising and enhancing our implementation plans. It's a work in progress. We set the priorities, but we make sure that we're constantly, keeping a pulse on what's happening within our patient community and adapting as we see fit. So tonight, what you're going to be hearing more is the detailed implementation plans of the 4 priorities that were established back in 2020, and then a little bit of going into a discussion more about what's ahead. So without further ado, I would like to turn it over to our president and CEO, Dr. Robert Vissers. I'll be back later.
Thank you, Grant. Why don't we move ahead a few slides here? One more. Great. I think I'll start with this slide. A lot to be proud of. The incredible care that we provide every day, lives saved, the engagement that we have with our community. But what I love about this evening is we get to share with you those extra and those important things that we do every day to meet your needs, that go above and beyond what you would tend to expect from a community hospital or provider. Another thing to be very proud of is we're 100 years old this year. And it's been a wonderful opportunity to reflect on our amazing past, but also to gain excitement about what our future really holds for us. But what this really means to me is when I look back 100 years ago, BCH was born from the vision and the collaboration and partnership of the Boulder community and some providers in the community. And they got together and they built a hospital, and has grown to what we all enjoy today. But during that entire time, we've remained an independent, nonprofit community health system. It includes our hospital, but many other elements. Next slide, please. Throughout the Boulder Valley. While I'm not going to go into detail about what every one of these dots represents, you can see our presence extends far beyond the Foothills campus, where we've consolidated our practice into 170 licensed inpatient beds. But throughout the region, we have 15 specialty care clinics, 11 primary care clinics. We have the Lafayette Community Medical Center. We also have a medical center in Erie, a freestanding ED in Lafayette. We have been able to succeed through a lot of strategic partnerships, both with other nonprofits, members and the whole entire community, as well as other healthcare entities, such as our partnership with UC Health to provide inpatient rehab beds in Broomfield. I'm particularly proud of our Della Cava Family Medical Pavilion. This is a $50 million state-of-the-art mental health inpatient and outpatient facility that was specifically built to serve the mental health needs of our community, and is an outstanding example of an outcome of our community needs assessment. We've built a Boulder Valley Care Network where we work very closely with the independent providers throughout Boulder County and beyond to provide an integrated level of high quality, high value care. Next slide. One of the things that's critical, and I believe is the reason why it's important for us to maintain autonomy around our finances and in particular our governance, is we get to choose how we spend our dollars, how we focus our care, and making sure that we provide the highest quality care locally to our community. But it doesn't mean anything unless we take the value that we have and we make sure we give it back, and we make sure that we give it to our entire population and those that we serve within our broader community, meaning we do the best we can to create equitable care and access. This requires a lot of charity care, and so I'm very proud to say that BCH provides $50 million of charity or discounted care for the patients that we serve within the region. If you consider that we're a $350 million organization, that means $1 in $7 that we bring back into the community to provide access and care to those that can't afford or access it. Next slide, please. Everything we do is guided by our vision, a vision that we created in partnership with many of you and our community members. And our vision is partnering to create and care for the healthiest community in the nation. It's aspirational, but it also recognizes that we need to partner, and that our goal is not just to be there to take care of you when your health is in jeopardy or when you're ill or when you've been in an accident, but that we're actually creating health and that we need to partner with you to create that health. It also means we need to listen to you. And tonight you're going to hear many of the things and the programs that we've brought forward through your feedback and what you identified as something that our community needs from your healthcare providers and system. Next slide. There are really 4 areas that were primarily identified in our community needs assessment that we've been working on, and we want to share our successes with you. One is mental health, chronic pain management, and substance abuse. We have made tremendous strides, and we've invested an incredible amount of time and energy and our resources into this, but we recognize that we still have a long way to go to meet this unmet need. Number 2 is wellness, preventative care, and access to care. And that's that creation of health, but also making sure we pay attention to equity. Number 3 is chronic disease management, and also traumatic injury. And then finally, working with our community and educating our community so that they are able to participate in the healthcare that we provide, but also work with us to build that healthiest community in the nation. Next slide. We also encourage questions. And in fact, what we're soliciting is feedback, responses, and helping us to design our further needs assessment and give us direction in terms of how we can better meet the health needs of Boulder Valley. There are several ways you can submit the questions. You can do them in the chat, which we'll try and answer at the end of the presentation. You can submit them online, or there's an email form post-event where you can post the questions, and we will do our best to answer all of the email questions and any questions that we don't get to during this presentation. So again, thank you for joining us. I'm incredibly proud of what we've accomplished with you, and please continue to listen so you can hear about our incredible accomplishments. Thank you.
Thank you, Rob. Again, my name is Sarah Wise. I'm the Director of Nursing for Behavioral Health Services. Next slide, please. I wanted to get you caught up on what you have seen happen in mental health, substance use, and pain management, especially chronic pain management at Boulder Community Health. Next slide, please. We have, over the past several years, established our commitment to behavioral health, substance use disorder, and chronic pain management. We've seen that in the building of the Della Cava Medical Pavilion, which, as Rob mentioned, is both inpatient and outpatient behavioral health services. We have grown the partnerships that we have throughout the community and have brought more of our stakeholders to the table. And we have started to develop and recognize the gaps that we have in our continuum of care and have closed those gaps, especially with the support of our community through the BCH Foundation, through the Anchor Point Mental Health Endowment. Next slide, please. And what we're starting to focus on this year then, and for the next several years, is the integration of all of these services that we have developed, the optimization of the resources that we have started to provide the community and established in the community in the last couple of years. And so this image is giving you a visual of this step up and step down continuum of care that we are developing in substance use disorder and mental health services. And of course, our chronic pain patients are included in this work. So you can see that our patients will be able to move from where life is going well, things, they're able to self-regulate, maybe something happens and things start to shift, they'll go into their primary care. We have embedded behavioral health specialists in our primary care that will work with people, and they will collaborate with our psychiatric services. If they determine through that collaboration that maybe some more focused care is needed, then people can move into our outpatient psychiatric and psychotherapy services. And that includes the different levels of care inside outpatient behavioral health. So we have what are called intensive outpatient programs, partial hospitalization programs, and those are just different levels of care where we can step up or step down the actual support that people are getting in terms of individual and group therapy. And then if needed, of course, we have our beautiful state-of-the-art, spacious, bright, welcoming, therapeutic, healing inpatient behavioral health unit. And we have people that come into that unit through our emergency room, through crisis centers, through community partners, and then also through this step up, this ladder that we've created. And if people are in crisis and they need emergency type care, then they can go into our ED, and we have psychiatric care embedded into our ED. We also have psychiatric care embedded into Foothills Hospital. So if you have psychiatric or substance use comorbidities where you're coming into the hospital for a medical reason, we have psychiatrist, psychiatric nurse in the hospital that will help support you through your medical stay with whatever is going on with depression, if there's suicidality that has been triggered, if there's substance use disorders that are being triggered because of what's going on in your life, then we have specialty care in Foothills Hospital. And so this is our work. This is what you're going to see grow and integrate. We are committed to no wrong door approach. So wherever you step in, whether it's through primary care, the hospital, medical, the emergency room, you step into this continuum of care. And this continuum of care within the organization extends out into the community through the navigation services that we have. So we have navigators that will follow you after your discharge from one of these programs back into the community and make sure that you're connected to community resources, make sure that you're getting to your appointments, that you have transportation, that you have the medications that you need, to help you problem solve anything that's coming up unexpectedly as you're stepping back into your life. So that coordination of care and navigation continues even past the services that we provide inside the service line. Next slide, please. And in addition to this, these are some of the programs that I've already mentioned and some of the programs that have come into existence recently in the last year or so, and then programs that are developing. So as I mentioned, the Della Cava Medical Pavilion is the center, the heart of our behavioral health services, beautiful building. Our Pillar program is another incredible program. Again, this is almost, it's a collaborative of community partners where we have navigation services that are helping people with substance use disorders find their way through what can be a very complex maze of resources in our community. And what we're doing with that program is that we're actually adding outpatient levels of care. We're adding some group therapy programs, IOPs and PHPs, and then we'll be doing some inpatient work through the Pillar program for substance use disorder services. And our Pathways program is our nature-based program. So this is where we took the partnership that we've had with Open Space Mountain Parks and the incredible privilege that we have of living in beautiful Boulder Valley and on these lands. And we combined that with our intention and commitment to behavioral health and substance use disorder care to create Pathways, which is a program. Again, it's an IOP and a PHP. So this is a group program where you come to Della Cava, and then as a group, we go out literally on a trail and go hiking for group therapy, so that we are using nature. We're paying attention to how the surroundings that we have help heal us, and we're actually helping people instead of saying, it's a good idea to go for a hike. Nature heals you. There's a lot of known benefits for being out in nature. We actually take you. We take you by the hand and literally go there. And then, we help you, explore your experience there and understand what's happening and learn things about yourself and your internal experiences, as a result of relating to nature. And our Anchor Point Mental Health Endowment, again, this is such a game changer in this community. I just can't tell you enough what a difference this makes. This gives us access to resources to help close some of the gaps that come up when you're experiencing behavioral health and substance use disorder services. This helps with short-term needs around housing, food instability, transportation, access to care, and can really just help bridge some of those short-term gaps that we experience when our behavioral health gets destabilized. And then, of course, our continuum of care, this is where we're working with our primary care folks to help provide psychiatric care to people in a population health level, in the community with, as you're going to your primary care doctor, you can have access to behavioral health services and psychiatric consultation. Next slide, please. So I want to change topic a little bit and start talking about health equity and belonging. So health equity, behavioral health and substance use disorder absolutely shows up as a determinant of our ability to potentiate our wellness. And inside health equity is embedded diversity, equity, inclusion, and belonging. And so we are in a process right now of really looking at what that means, and really looking at our power, our privilege, our position, our biases, our implicit biases, and understanding how oppression happens, how it happens on an internal level, how it's happening on an interpersonal level, how it's happening on an institutional level, on that system level, where some of the systematic oppression of people just becomes a barrier that people can't get past on their own, and that we are taking our responsibility for identifying those barriers, identifying our oppression, understanding it, and creating and turning our work towards anti-oppression more and more and more, and then using that knowledge and those skills and that insight to deal with the health disparities that we have in our community and that we have within our organization. And we are also very focused right now, especially on the data and making sure that our data is complete, it's comprehensive. We're getting all of the sexual orientation, gender identity. We're getting really thoughtful and inclusive race data, so that it's not just, what race are you, but how do you identify? What races do you identify with? And how does that, what do you want to bring in so that we know these things about you? Your ethnicity, your age, your language, your abilities. So all of this, we're working on making that data much more complete, and then working on a process of stratifying, using that data to stratify our outcomes in our programs so that we can better identify these disparities, target our efforts to close those disparities, and be able to monitor the effects so that we know that we're actually changing the things that we need to change. And with that, I will pass it on. Again, I'm very grateful to be here. I appreciate the opportunity to serve BCH and Boulder community, and I look forward to your questions and requests and insights as it relates to behavioral health.
When you speak and certainly feel energized about the work you and your team are leading, and very proud to be a part of that as well. And so thank you. And good evening, everybody. Again, this is Larry Nivissimo. I again have the pleasure of serving as the Vice President of Ambulatory Operations here at Boulder Community Health. And I even have to explain to my family sometimes what does ambulatory mean, and basically it's a fancy way of saying I have the pleasure to lead and work with all of our amazing Boulder Community Health physicians, nurse practitioners, our medical assistants, our clinic managers, all the folks that our community members would see when they go to a clinic office or a clinic visit. And so again, that's my area of leadership within the health system. And this connects very well with a lot of the things that Sarah was just discussing. I think it's important to understand that while we are all presenting various components of our organization and our system, they're all very much intertwined and rely on each other to be successful together. And I think being a smaller a community organization, leaders know each other, providers know each other. We know how to interact. We know how to help patients navigate the system. to certainly break down barriers and make sure there's continuity of care, coordination of care for patients and families. And it's just a really neat organization to be a part of. And while we certainly always have places to improve, I do believe our organization, led by our amazing physicians and nurse practitioners, our nurses, everybody does an amazing job with that in mind. So next slide, please. And I'm going to touch a little bit on some of BCH's wellness and preventative health and access to care strategies. Next slide. Thank you. I'll share a couple highlights, but I think also it's important to realize that a lot of health and wellness and preventative care, access to care, may be obvious to some, but not always. It really starts with strong primary care. Community Health has for many decades had a very strong strategic plan and operation around providing excellent primary care within our community, whether that's our family medicine clinics, our internal medicine clinics, having a strong primary care base with very passionate primary providers to help keep people well, to help people develop plans to keep them healthy, to promote preventative health. That's just been such a key component of community health, and something that I think we do very well. I do believe it separates us from other organizations in the community, and I have the pleasure of recruiting physicians to our medical group as well, and it's something to highlight, and it's something that is well known externally as well when we're speaking to provider candidates who have sought out as a place that they want to practice medicine and take care of patients. So I'll highlight a couple of components here that address this particular need within our. And one of the big ones here is our annual wellness visits. And we just wanted to share a little bit of a stat there. We put an extra focus on it throughout 2021 and continuing in 2022 on our annual wellness visits. These are visits that patients' insurance companies, whether it's Medicare or a private insurance company, a United or an Aetna, Cigna. These are visits that are covered by our insurance companies, and we are allowed to bring these patients in on a yearly basis. We have an active approach. Call these patients, bring them in, have them speak to their primary care physician, and really do that yearly wellness visit. Talk about medications. Talk about things that might be going well. Talk about things that are not going well. Plan for various diagnostic tests. Plan for the future. Speak about their family. Listen to their concerns. Address potential mental health issues or stressors in the life, and really just spend that time with their primary care physician to do what's needed. It's a special time that a primary care physician gets to take a few moments and just sit and speak to their patients and the potential patient spouses and families, and really establish that care plan for the year. And so we've been very proud. A lot of effort has gone into making those wellness visits more robust and meaningful, and bringing more people in and helping patients understand the value of that. Another component that we want to highlight here is through the use of our electronic health record, Epic. We've got the MyBCH secure online patient health management tool, often just known as our ability for patients to send messages into their physician or to the care management team. As patients, we're able to log into our chart, our portal account, and we can look at lab work or medication dosages that we're supposed to be on. Patients can submit for refills. Again, they can submit questions. So it creates a much more interactive way for patients to interact with their physician, with their care team from their clinic, to be more directly involved in the care that they're seeking and that they're receiving. And through the use of this technology, it's really a way an additional way for patients in our community to stay connected and and get care that they may need in between their office visits. Just the third piece to highlight here, we've got a very robust patient helpline, and again, this is an overnight, 5 p.m. to 8 a.m. and all weekend long patient helpline that is staffed by experienced nursing personnel. And when someone calls their clinic after hours in the week or on the weekends, they're able to receive on the other end of that line, they receive a nurse. That nurse is trained in all the various current state nurse triage guidelines, ways to help patients. They can answer questions. They can triage those issues. They can direct people to urgent cares. They can direct people to the emergency room if needed. They can schedule patients for appointments for the following week. This is not only a wonderful service for patients to get that care after hours and find the right place to care, but also helps reduce hospitalizations. These nurses are, again, specifically trained and experienced to really ask those questions, to dig deep with that caller and really determine the best place for them to receive the care that they need. Again, the answer is not always just go to the emergency room. It's costly for the health system. It's costly for patients. It can utilize resources that are better reserved for true emergencies. And so this has been an extremely successful program at Boulder Community Health. And this is not something new. This is something we've had in place for many years, but we are certainly talking about it this evening and feel like it's one of those behind the scenes functions within our service offerings that it's not necessarily known until you utilize it. We get tremendous feedback from patients and from our providers as well. Next slide. And there are a couple of different ways that BCH does engage with our community to improve access to care, to highlight access of care, to function as maybe another front door on how to approach the health system or find the care that you may need. And just highlighting two real specific ones here over this past year. BCH has supported the health and wellness of our community over this past year in these two specific ways. One way is what we refer to as the Be Well Saturdays and the Movement Challenge. The Movement Challenge was a 30-day challenge that included some free provider-led walks all around Boulder County. There were walks that occurred in Boulder, Erie, Lafayette, Longmont, and Louisville. And then the 30-day challenge, we had about 8,400 patients and community members entered into a way we were making it fun to track and enter it. We have 8,400 people entered their personal information around their walking, their running, their gardening, biking, any movements that they did for approximately a 30-day period. And there were recognitions and prizes. Again, just a fun way to engage community, engage us all in and how we can be active over the summer and how we can track that. I think it's something that I've learned a lot working with primary care physicians over the years, and something that I'm very proud of the part of it, Boulder Community Health. Our primary care physicians themselves are very often very active and lead active lifestyles and do all kinds of interesting things. And there's a lot of promotion within our physicians and APPs to engage their patients in their own healthcare. So it's not just about I don't feel well or I have a need to address, but one important thing that we've done for many years is how do our providers engage their patients, engage families in developing their own ways to improve their care, to improve their wellness. If we can lead those conversations, guide those conversations with our patients. I know my own physician, a Boulder Community Health physician, has helped develop that as well. Sometimes we all just need a little bit of extra help or a little bit of encouragement from our trusted primary care provider to help us set those goals and then work on it together. And so it's a special relationship that we're able to garner between our patients and our physicians. Again, not just our primary care physicians, but many of our specialists as well. And it's something we take very seriously. We often talk about every patient, every time. And so the ability for our physicians to spend that extra critical time with their patients or with the patient and their spouse or family to listen, to understand, and develop what's going to work well for that individual to improve their wellness, to address their preventative health needs, and to make sure they have the access they need. We have the ability within our health system to really personalize that, and it's a really special thing. Next slide, please. And I drew the long straw here, I guess. I just have the pleasure to be able to share this information related to just our absolutely extraordinary response to the largest healthcare emergency that I know many of us will experience in our lives, of course, the COVID-19 pandemic. It's hard to put into words and onto one slide the response that the providers, the front desk folks, the scheduling people, the information technology folks, the supply chain folks, the facilities teams, just such an incredible team effort in the spring of 2020 when the world changed and we all absorbed what was happening. And what we did very quickly within Boulder Community Health is what we do best. People came together. There was a community health need. We rolled up our sleeves, we put our masks on, we set up our command center, and we all came to work. And it was scary. We didn't know what was we didn't know where to go or what was going to happen. But just an incredible group of people that had one thing in mind, which was, how do we address this within our community here? How do we make this happen quickly? And how do we put this all together? Just when you sit back and think about it, now I have the luxury to sit back and think about that, and just I'm in awe at how quickly and efficiently this whole thing came together for us. It was scary at the time, but time was slowing down, but also moving fast at the same time. And again, now, 2.5 years later, being able to look back and really understand what the team was able to pull off, it's just incredible, and just super humbled and proud to be a part of that team. And just some statistics here that we'd like to share around this. We delivered over 120,000 doses of vaccine to approximately 56,000 people. Had 350 retrained and redeployed employees as part of our response. Again, this could be taking medical assistants from clinics that were closed temporarily and training them how to work in the hospital. This could be administrators and non-clinical people like myself getting trained on how to run equipment or how to help clinical staff put on their personal protective equipment and take it off. And there's just everybody learning new skills very quickly to be able to help the cause. We also came up with very creative ways to be prepared in many different ways. And again, just I don't think any of us that were part of this part of history working at Boulder Community Health, we're going to remember this for a long time, and it's something that we are certainly extremely proud of. And I honestly can't imagine going back with another group of people outside of what we did at Boulder Community Health. And so again, that's an important highlight that we wanted to share related to our pandemic response and our vaccine clinic. Next slide. Right, I'm going to turn it over to Ben.
And I think Larry and Sarah articulated pretty well, but we separated this talk or this presentation up, but it's artificial because primary care prevention and mental health work really are intricately involved in chronic disease management, acute disease management, traumatic illness as well, and the care teams and support that we provide are often overlapping and similar. So I think you'll see a lot of the similarities. Next slide, please. As we talk about chronic disease management, traumatic injury, I would also say prevention of traumatic injury and prevention of chronic diseases have been somewhat covered already, but those are very important aspects of our program. And as a primary care doc, Larry was talking about primary care docs, and who spent a lot of time in the hospital and in the clinic, it's something I'm really proud of, and I think I can maybe articulate some of the benefits of this program. Next slide. So, when you think of chronic diseases, we think of the classics like diabetes, obesity, congestive heart failure, depression, substance abuse or dependence. And the goal is to improve the health and quality of life while improving value and decreasing costs. But that's, that's kind of the maybe more formal way of putting it. I look at it as really a transformation from the way it used to be, I think 15 or 20 years ago, where, a patient would come in and talk to their primary care doc, and we would put some orders or make some plans and talk about it, and then they would go on their way. Well, now we've sort of built over about 12 or so years this group of people to help our patients, help our primary care docs work together to deliver better care, which is particularly relevant in most of those chronic diseases. So if you think about, next slide, some of the ways that we've really maybe more thoughtfully address things like diabetes, instead of just thinking about how do I adjust meds and what can I talk to my patient about diet. Now we have an integrated clinical team that's supported by Optum, one of our key partners, which involves a nurse, it involves a diabetic educator, it involves a pharmacist, a behavioral health specialist, as Sarah mentioned. We have access to geriatrician in our network, neurologist, data analytics. And so combining all of this to have a different approach, where we sometimes use techniques like motivational interviewing to help patients come up with their own motivation for improvement and change. Sometimes, for example, I saw a diabetic patient who was really just sort of struggling to get their numbers under control. And instead of just adjusting the meds and adding insulin, he was referred to our diabetic educator, who helped him get a continuous blood glucose monitor, learn how to use it, learn how to interpret it, plugged him in with nutritional resources, and really can get the same level of improvement or even better without adding medications. Or if we see a patient with depression or anxiety, we can supplement the care that we provide in primary care with a mental health resource to help with whether it be therapy, referral to a higher level of care. So it's really been a huge change. As a primary care doc, I really feel that our patients are much more supported navigating these types of problems than they have been in the past. We also partner with the community resources such as the Area Agency on Aging and Boulder County Public Health. And sometimes there are resources that we don't have, but they're in our community. So we work really closely together, and that has been a really great collaboration. Next slide. Rob Bissers mentioned our clinically integrated network, which is a big term, but it's essentially partnering all the BCH providers and hospital services with our independent physicians. So there's more than 500 of us as part of the Boulder Valley Care Network. And so this allows for things that, orthopedic care or neurosurgical or other services that we often partner. We can sort of seamlessly work with our partners, communicate, share information, imaging, some of the resources like transitional care nurses that help our patients when they're leaving the hospital after, let's say, some kind of major surgery, help them make sure there's not a problem during that really critical transition. And our BVCN is contracting with payers to provide these types of services at higher quality. So, and I'll show you some quality data in a second, and at the lowest cost. And so actually it's on this slide, but we for the last 3 years, we have had the top quality in the state for our Medicare shared savings program. We're very proud of that. We've also had accolades in some of our private payers as well. Next slide. This slide, it's a little hard to unpack. I'll try to explain it, and maybe don't worry about the details. But this is a report from the Medicare, and it's looking at the average payment for the cost of care per beneficiary. So it's a national data set. And what this shows is we're 0.96. One would be the mean. We're 4% below average in total cost of care. So I told you that we had the highest quality in the state for 3 years in a row. We also have lower than expected cost. And that's because we're using this team-based approach, and we're using a combination of the highest, most expensive and amazing technologies with some lower technology things like communication skills, teamwork, wrapping around services to help provide the care. Next slide. So transitioning from chronic disease management, which is a huge concern for our community. But also, you know, one of the key things that hospitals provide is trauma care. And when you get hospitalized with trauma, which I mean like a car accident or a bike accident, or in Boulder, let's say a mountain biking accident or a rock climbing or skiing accident, it makes me really proud to see the type of level 2 trauma care. The highest level in the state is level 1. That's only a couple of really large academic centers that have a teaching mission. We are the next level, which is the highest level a community organization can achieve, level 2, which means we have 24/7 in the hospital anesthesia, general surgery, trauma surgery, hospital medicine. Intensive care support. So we really have increased our services in trauma over the few years with quite a bit of resources. For example, we hired our first specialty trained general surgeon who is a traumatologist trained at shock trauma. That's our trauma medical director, Dr. Harmon. We also recently partnered with our orthopedic group to bring a orthopedic trauma specialized orthopedic surgeon to help us really improve our program, because like chronic disease, trauma is not just acute care, but it's a system of care, and it can be quite complicated if you have major trauma where there may be multiple doctors involved from multiple specialties. So you really need a whole program involved to help support our patients. We do a lot of emergency preparedness, as Larry was talking about COVID pandemic, which gave me a little bit of flashbacks. But fortunately, we have an amazing emergency preparedness team that partnered with us as we delivered COVID care. And then we have a really amazing inpatient rehab unit that's a partner with UC Health in Broomfield, where some of our trauma patients, but also a lot of our stroke and other patients go for intensive rehabilitation after hospitalization. Next slide. And then again, you know, getting back to some prevention and integrated into our trauma program is outreach, education, and activities, and bike rodeos, bike to work days, back to school events, stop the bleed, fall prevention programs, both online and in person, child and teen safety. I hear about this at our monthly trauma meeting. It's really impressive. The trauma team gave out something like 400 bike helmets already this year. And they continue to do bike to work events and bike helmets and bike fitting throughout the pandemic, which there's a picture there that makes me smile. And meditation classes and other educational sessions. We also do a lot of chronic disease management educational events as well to our community, whether that be advanced care planning discussions, diabetes management, prevention, etc. Next slide. So a little more on community education. You can go one more. There's just a few stats that just show we were a little worried when COVID happened that our education was going to really be hard to uphold. But what we saw was actually a doubling in the amount of people that were watching our educational events. Obviously, it's a little easier to just log online. And so you can see the stats. And we've been able to provide more education to a broader group of people since we shifted to being able to do online programming. Next slide. We have a large amount of provider-led education, which I mentioned. And next slide. I think there's more on HTP. Next slide. So a hospital transformation program, this is also something we would like to hear some community feedback from you. This is a required program through Colorado's Medicaid program. Next slide. And it's a quality improvement program. It's meant to improve quality of hospital care and reduce cost for Medicaid patients. Next slide. And we were asked to choose some goals to improve the care, and what we focused on readmission prevention. So when you leave the hospital, avoiding and coming back unexpectedly. Improved care coordination, so after discharge, sending records and getting really agreed upon what we will share with our partners when people come and go to the hospital. Improving access to specialty care, including for the underserved population, such as Medicaid and the uninsured. A lot of really great work on opioid dependence, including alternatives to treatments, prevention and treatment, medical assisted treatment in the emergency department, in the ICU, and the outpatient clinic. Really amazing stuff. And then creating some data reporting systems and screening for social determinant of health, starting to interpret that data and trying to make sure that we use what we screen so that we can connect people and help solve some of these problems as best as possible. And I think, so those are our goals for HTP. There's a lot to put in there, and I want to make sure we have times for questions. So I'm going to leave the details to answer questions. There's a slide, I think it was out of order too, back on just the live chat. And I'll turn it over to Graham.
All righty, back in action here. We covered a lot of territory tonight between Dr. Vissers and Dr. Kaiden and Larry, as well as Sarah. So I want to make sure that we give the audience the opportunity to ask questions. There are 3 ways to do that. You can submit through the chat that is within the live stream. You can also, after the event this evening, submit online through bch.org/. Sure, I'm having a hard time seeing the screen here. Is that HTTP? Looks like HTTP. And then you can also email the form for post-event questions, but we will also send a follow-up to make sure everybody has that information. So if you have not done so already, please submit your questions. I think at this point, we will go to a screen with all the panelists, if that's okay.
We're offering the Pfizer bivalent booster. We got our first shipment, I think, a week or so ago, and began with our employees, and now we're offering it to our patients. And the recommendation is anyone who's completed the initial 2 series shots can get the bivalent booster, and you can get it at BCH. You could also get it at any pharmacy. There's a recommendation that's waiting 2 months from last vaccination if you had a recent vaccination. And some people are waiting after a recent COVID infection, although that guidance is less clear. And I'd say the majority of our primary care clinics have it available and are giving COVID vaccines, and a few have not yet received it, but they're working to arrange it for our patients that go to those clinics.
Certainly, yeah, great question. Within our employed BCH medical group, we have certainly cardiology, we have infectious disease, OBGYN, midwives, neurology, neurosurgery, general surgery and trauma surgery, and pulmonology, critical care physicians as well. And then we partner with a number of private practices within our clinic integrated network for orthopedic care, for GI care, for cancer care, oncology, and other various specialties, ear, nose, and throat, and a couple of other subspecialties. And so we've got a very robust specialty care network that our primary physicians can access for expanded care if patients need, or patients have the ability to directly seek care with specialists. For our size community health system, we really have all the specialty bases covered, and it's a wonderful network.
Excellent. Thanks, Larry. Let's jump over to behavioral health. There's a number of questions that have come in related to that. So Sarah, thank you for the comprehensive overview before and kind of talking about the step up, step down kind of vision, aspirational vision that we're working toward right now. Can you share a little bit more about our inpatient unit and kind of what occurs there? What do we offer? What type of services there?
Yeah, so the inpatient unit is primarily our focus on the inpatient unit is crisis stabilization. So when somebody comes in, they are generally in a state of crisis where things have just gotten so severe that they're concerned about their safety, they're concerned about the safety of others, they're concerned about their ability to care for themselves on their own. And so people will come to the inpatient unit. Our average length of stay right now is about 5 days. And during that time, they're working very closely with our psychiatrists and who are helping with the medication. So we'll be doing some medication management. But in addition to the medication management, there are group therapy throughout the day. So we have group 6 or 7 times a day. The groups have different focuses. One of the things about our unit, as I mentioned, it's a beautiful state-of-the-art unit. In the middle of our inpatient unit is an outdoor garden. So you're able to go outside. You know, there's time every day that people can be going outside, sitting in the sun. There's gorgeous plants. It's just a very therapeutic, healing environment out there. We also have art therapy. We have insight groups. We're doing adding some movement groups. We have a chaplain actually that is just finishing a yoga certification in trauma-informed yoga. And so they will be coming over and doing a yoga group several times a week. We have a Reiki practitioner that comes up once a week and offers Reiki to the patients. And so there's a lot of time that's just spent, you know, learning, you know, feeling comfortable, like in a safe, trusting space where you can connect with people, where you can start talking about things, where you can start sorting through things. It's a protected environment so that some of the stresses that are maybe complicating behavioral health are limited. We work with the families. There's visiting every day. Families can come and visit every day. And then there's also, we do family meetings so that we can work with the people that you're living with and resourcing outside of the inpatient unit. And then we are also, you know, talking about what's next. You know, what do you need to do next? Do you need to step down to another level of care? Are you ready to go back to the providers that you were working with before you came in? You know, what does this look like as the next step?
That's great. Thank you, Sarah. Next question is, does Boulder Community Health receive funding from the city or the county? So the city of Boulder or through Boulder County? I can give a shot at answering that. But the city of Boulder and the county are very important partners to us, you know, from a population health point of view. And clearly COVID was a good illustration of that. And Ben, maybe you could speak about that in a second, because in terms of the cross-agency collaboration that occurred. From a funding point of view, we've been incredibly fortunate to be a grant recipient from the Health Equity Fund. And that's specific for our pillar program that is specifically focused on substance use disorder. And really, we go very deep as it relates to opioid reduction, including the medically assisted treatment program that we have that's associated with that. So Ben, I think it's always interesting to talk about COVID and kind of the increased collaboration that happened across agencies, both at the city and county level. Maybe you could quickly share about that.
Yeah, I mean, I think it's important to point out we collaborated pretty closely, not just city and county, but also statewide. So the state health department, the state system, other systems, health systems. The county has been a really good partner. We're on first name basis as we work well together. I think we try to be good partners and support them. So if they have groups of people they needed vaccinated, for example, we were always yes. They sometimes had some volunteers that they helped us for our volunteer workforce. We partnered with them around planning, around prevention, you know, for some of the county, there were some orders around, you know, masking and social distancing. So we just worked really closely with them. They're not really much of a funding stream outside of the pillar program, but they have some resources that we don't have, and we have resources they don't have, and we have a shared vision and passion for creating healthy communities. And so I think it's been a really, really strong partnership.
Thank you. Larry was referencing earlier kind of the breadth and depth of services that we offer. This question is also kind of directed to either, I guess, Dr. Kiden or Larry to answer. So how come, being an independent, small community health system, how comprehensive is the care that we provide, with across Boulder Valley in comparison to some larger hospitals, either on the Front Range or that you see across the country in comparison?
I might start with that, Larry. I think having come from a really large academic center in Boston, I had some thoughts that this would be a real big change, that we were going to be really community hospital. I was pleasantly surprised that because of Boulder being where it is, and because of BCH being the kind of facility it is, we have almost the entirety of medical and surgical specialties. And not just that, but people that trained at Harvard and Stanford and UCLA and Johns Hopkins, and people that come here because they're extremely successful and smart and hardworking, and they want to live in a really amazing place that provides great care. And so we have pretty much all surgical specialties with some very minor exceptions, which, we don't have a very robust transplant surgery. We don't do that. We don't do some really advanced heart failure treatments, but we do almost everything else, cardiovascular, from heart surgery to endovascular, really a pretty comprehensive care across almost all specialties. But there's a few things that, we partner with, like we don't do ECMO, which is the sort of heart-lung bypass that people used for COVID. So I think 2 or 3 times during the pandemic, we sent them to our partners at the university and had a really great experience, and it worked really well. And so we don't do interventional stroke work. So we work with Swedish, and they do a really great job of that. But fairly comprehensive, much more comprehensive than you would get at a lot of smaller communities, and very few gaps. And so what we've done is really tried to focus on partnership. When we do have a gap, we just have a strong partner that we work together with, and that has been, I think, a very successful approach.
That was a really comprehensive answer there. Larry, do you have anything else to add on that from your view on the ambulatory side?
Dr. Kai did a great job there. I guess the only point I was going to add, and Benny kind of touched on it, was again, as I mentioned earlier, I have this wonderful part of my job where I get to recruit physicians, and I often hear that when we're recruiting primary care or specialty care, we hear from candidates, I've done my research. You guys have this excellent medical staff, very comprehensive specialty network. Again, within the direct environment, with also within your care, and so it attracts these amazing clinicians, whether they're physicians, nurse practitioners, PAs. It is noticed, and it attracts more excellent clinical providers, and so it makes it enjoyable to recruit and be able to talk about our teams a little bit, and especially for primary care physicians. And Ben can speak to this too, being able to have those services available. So when your patient presents, or you're helping manage their care in a broader way, most of this care, majority of this care, is local. Patients can receive that care close to home, close to where they work. They do not have to travel very far. Again, if it's something very specific that they do need to go out of the immediate Boulder County area for, we've got excellent partners who are just as passionate as we are about providing that care, and we have those relationships, and we make it work.
One of the areas that I was remiss in mentioning earlier as I was rushing through the end slides was about our community partnerships, which I think is a nice segue from some of the topics that you've been covering. And BCH's vision is a partner to create and care for the healthiest community in the nation. And we know that we can't do that alone. And you've heard us reference our partners on the clinical side, as well as city and county and state agencies there. But we also work with a number of nonprofit organizations across the community that are really incredibly critical to our ability to go upstream and downstream, in the care of individuals. And when you think about social determinants of health, whether it's housing or nutrition or transportation or aging or isolation that is occurring, who are the partners that we need to be collaborating with? So we work with everybody from Boulder County AIDS Project for HIV and hepatitis prevention to Blue Sky Bridge for pediatric physical sexual assaults, to Bridge House and Boulder Shelter, specifically to individuals that are experiencing homelessness, and making sure that we're providing the best handoffs and also enabling individuals to work toward housing, over time. So this is an area that we continue to build upon. We've learned a lot, through prioritizing this within the current strategy, and something that we really look to expand going forward. So last but not least, unless there's any other questions coming in, we're kind of, I guess, gone from pandemic to endemic at this point, and BCH has learned quite a bit. Are we ready for a future pandemic if one was to occur? So, Dr. Kine, probably a good question for you.
Let's hope not. But yeah, I think we are ready. And frankly, this was an exercise in really dusting off our preparedness chops. And also, we built these partnerships across the state and across really there's some national partnerships that we created. And so I think we're ready as we can be. And it's a little tricky not knowing what the next thing could be. But some of the things we did, like the ability to vaccinate, the ability to change and deliver new therapeutics like monoclonal antibodies, like other Paxlovid and things like that, telehealth. I mean, I was amazed how quickly we got all these things going. And I really have confidence that this team can face any threat.
Well, I think that's a good note to end on. Sam, if you could take me back to the slide that shares how people can provide feedback. But I did want to thank Dr. Kine, Dr. Visser, Sarah Wise, Larry Novissimo for taking the time tonight to share kind of the expansive work that is underway. I also want to thank everybody that took the time this evening to join us for the town hall. I think going back to the pandemic, it was a community was our greatest asset, throughout the pandemic. So whether it was collecting PPE early in the pandemic, to partnering with CU Boulder, as well as the pharma community as related to testing, to us getting ready for various treatment modalities and the vaccine, it really has been the community that's been there at every single step along the way, including incredible financial support, through the foundation, which enabled us to be incredibly agile. So again, thank you for coming out tonight. Looks like we're flipping through slides here. If you could just give me one, there we go. Here is a summary again of where you can submit both online as well as the email address. We are collecting all that feedback. It is due by October 1st. So please take the time to think through your questions and let us know what's on your mind. So again, everybody, I really appreciate your time and enjoy the nice, cool evening. Be well.